everyone. We're very excited to tell you a little bit about our project that we're doing at Cambridge Health Alliance. My name is Mena. I'm a psychologist. I'm based in primary care. I do integrated services there. So I do consultations and treatments. And Jesse, you can introduce yourself.
Hi, everyone. I've been the annoying one asking questions throughout the session today. I'm Jessie. I'm a dietitian. I also work at Cambridge Health Alliance. We're a large organization just outside Boston. I think there's 3 hospitals, and I think there's at least 16 primary care outpatient clinics, but that doesn't include the specialty clinics. So there's more than that I support at least all those 16, if not more, in our outpatient nutrition program. So,
Okay, so just an outline of what we'll be talking about. We're going to give a brief background of what led us to decide to do the project that we're doing in primary care, the aims of the project, what exactly it looked like, and then give you some examples actually of what the intervention looked like, and then go over the results and figures and the conclusions. And then we'd love to hear everyone's input about our next steps. So we're hope from this presentation today is that you all are able to kind of think about together as a group possible interventions in primary care for children with obesity, and thinking specifically about how do we incorporate interdisciplinary and multicultural frameworks in treating pediatric obesity. And then we'll give you just our small kind of pilot example of what we've been doing so far.
So I think he's Rohit. I don't know if he's here anymore, but he gave a really good job of providing some background already. But briefly, the prevalence of obesity, as we all know, in the U.S. has been steadily increasing over the past 15 years. And since the COVID pandemic, childhood obesity and mental health challenges have risen disproportionately, particularly for the children of color, which most of us, or the two of us, work for. And most primary care providers report needing additional support managing obesity within their pediatric population. And patients in primary care need effective, accessible, weight-inclusive interventions that significantly include mental health, especially those in low income and communities of color, which have been particularly affected by both of these crises. And the American Academy of Pediatrics guideline for the treatment of children, adolescents with obesity recommends at least 26 hours of intervention, and group-based care can fill this need.
So our project was a pilot specifically for children 9 to 13 years old. We decided on this age group because we were thinking that the younger children in elementary school and then older kids in high school have a different kind of developmental experience with their experience with nutrition or mental health. So we really wanted to focus on a specific age group. And we tried to make our program very culturally focused. And again, we really wanted that interdisciplinary work. And so we worked across pediatrics, nutrition, and behavioral health. And our idea is we wanted to see what we could do inside primary care, because a lot of the kids we know go outside of primary care and go into specialty care clinics. And for a lot of families, that's just not possible. And we lose a lot of people in that process of referrals. So our research was exploratory. We did a mixed method. So we looked at quantitative and qualitative data, and we wanted to see what would happen if we increased parental input and also behavioral health. If you kind of look at the research, a lot of the work is more focused on when it's in primary care. Sorry about that. It's more focused on either just primary care providers or maybe sometimes some input from nutrition. But we didn't find too much work in the research that had that combination of all three. And so our group were only 15 kids were recruited, 10 were enrolled, but we only had 4 who completed the program. And we'll talk more about kind of what our thoughts are about attrition and what our hopes are for the future and how to focus on that. And one thing to note, of course, is that our group curriculum was adapted from the MGH, the Massachusetts General Hospital Healthy Weight Clinic program. So we worked with a team there to adapt the program. So our measures were pre and post. The first one looked at child well-being, and that was strengths and difficulties questionnaire. And then we had parental stress, which was using the parental stress scale. And then we had 2 multiple choice questions, which Jesse actually created. So they were just looking at vegetables, fruit intake, and sugary beverage intake on a weekly basis. And then we had interviews. They were short, semi-structured interviews for the providers, the children, and the parents. And we looked at satisfaction and the knowledge they gained.
So as Mena described, is that we adapted the content from MGH's Healthy Weight Clinic program, and we adapted all of the content into 6 sessions. And so, for example, this first session, we really focused on the content or adapting it, focusing on the creating a healthy home. And from here, we expanded to really talking about increasing the kids' participation in what's the word I'm looking for? Family meals. And so what does that look like? Not just eating together, but also moving together as a family. And then we also wanted to open up this discussion to have the kids talk about what are their traditional and cultural meals, what do they look like in the home, like holidays and stuff like this, to give them a platform to talk about that, to educate each other, things like this, because we the clients or the customers or patients that we serve is a really diverse community. So having them talk about that with each other and let them learn from each other. We also adapted, like from session 2, we took out the content about portion sizes. We really didn't think that was really appropriate for this age group. Here are the session titles for sessions 4, 5, and 6. And by adapting the content, for example, we took out the content about label reading, and this allowed us to really spend a session and a half talking about behaviors and emotions, which I think, MGH, that the content really, they talked about it, but I think that really allowed us to build a lot more and spend some more time on that. So here are some example slides that we showed. These are slides just showing what are the 3 food groups, and this is designing your plate into the 3 sections, the percentages. I actually use these a lot with not just my kids, but also adult patients. And then here's another. And so here, and you'll notice here that this is a slide that shows more culturally relevant type of food, not just, potatoes and chicken, stuff like this. This is more catered towards our Latin population. And then here would be the other type of, the other slide or portion of the handout showing, which foods belong to each food group, for examples. And here are some slides that Mena would talk about during our group. And we tried to make them really interactive as much as possible, getting them to talk about using just single words and phrases if they didn't really want to talk a lot about it, getting them to interact with us as much as possible. Using pictures too, and hopefully not a lot of words. And this one I really liked when we did it with them, and getting them to write down on a piece of paper as well. And then if they felt comfortable to share it with us, and having them use the Google chat form if they didn't want to say it out loud too. I think they really felt comfortable to do that if they wanted to, which was good.
Okay, so for the results of our first pilot, Again, even though we had a very small group that we were looking at, it was interesting to kind of see that there was a change in familial stressors based on the parental stress scale. And I'll show you the graph specifically that and the numbers that we saw. And even though we heard a lot of acceptability from the participants, we did have that we had that attrition issue, and we're hoping that we can work on that in future pilots. So there weren't any other notable differences in the other pilot of the measures that we looked at. The qualitative interviews, though, were very interesting in terms of what we heard from the providers and the children and the parents. The providers talked about really loving the partnership across different disciplines. They believed that it did improve access, and the parents talked about how their children were sharing knowledge that they gained. And then children really, the ones who were actually with us, did enjoy the group. So here are some example quotes from the different groups that we did interviews with. You can see one child's talking about sharing this with their own individual therapist, wanting more time. So it was a 60-minute session. And parents did talk about how they were the children were sharing with them information about the group. And that, they were also sharing it with siblings. And so the providers that we spoke to were pediatricians who were involved, nutrition and behavioral health. And the big thing that we heard was just normalizing these conversations, and obviously feeling more welcome than a regular primary care visit, because we did try to make our group time fun. And this was a good opportunity to coordinate care across the different departments. So you can see I put the range there for the parental stress scale, but so they weren't necessarily reporting a very high level of stress, but we did see a difference in pre and post. The strengths and difficulties questionnaire was child report. And so the two kind of scales that I'm showing here that was interesting was they were already showing reporting pretty high pro-social skills and not that much difficulties in their life. So we didn't really see much of a difference pre and post. And just to kind of make note, one of our exclusion criteria was that we didn't have children who had any kind of severe mental health challenges. So our hope is kind of to use this group as a more preventative intervention.
So as Mena had mentioned earlier a little bit, is our attrition rate was challenged throughout both of the cycles that we've completed so far. And so basically one of the things that our attrition rate has suggested is that we should consider incorporating more cultural and family-focused content. So like including more cultural perspectives into our sessions and reducing the instructive content into our sessions, and continuing to make our sessions more interactive. And for future groups, making sure that we include more or future sessions, we include more focus groups with the families to explore these questions and figuring out how to continue to adapt. And because a successful implementation of an integrated obesity and behavioral health program for children requires increased coordination with parents and pediatricians.
So we had some ideas of how to increase the coordination with pediatricians. We know that they're all very busy. They have very busy schedules every day. So we thought about maybe even sending electronic messages through their electronic medical record as one way, or a phone call to just kind of check in with families, or even during a possible visit that they already have, to discuss the group, to provide that kind of encouragement and engagement and continued engagement in the group. Again, we want to really kind of use what we've learned and continue to get feedback from participants to inform future implementations and expanding it to different clinics. So far our pilot has been just in one of our primary care clinics, and then hopefully studying the program's long-term impact.
So we made some changes for our second session, or second pilot session, which was this past summer. And one of the things we changed was we decreased the just overall content on our PowerPoint slides. We used more polls during our Google Meet, so that was the idea, to make it more interactive. We also fixed a kind of operational glitch with the appointment type of the nutrition specific appointment types for the medical record. That was creating some confusion because we were using two different platforms for the patients. Unfortunately, we only had one consistent participant throughout the whole session, even though, well, we had one consistent the whole time. There was a few others intermittently, but we had 5 at the outset. And we think it was due to the following kind of barriers: just busy family schedules during the summer. This fortunately, forced us to explore some other potential changes that we wanted to make to the program that we're thinking about. But overall, just the need to recruit more participants at the start is one of them.
So this actually made us kind of step back and slow down and think about how can we get as many participants as possible from the very beginning, so we can really look at the data more thoughtfully. And one of our team members suggested that we look at the nutrition referral queue. So we have a very long nutrition referral queue, as in behavioral health as well, but we thought we could possibly find a lot of eligible participants in the nutrition referral queue who are waiting to be seen anyway, because we also have a shortage in our nutrition staff. So this was a way to kind of hopefully get more access to care. And knowing that a lot of the research, and also speaking with colleagues, is the attrition rate is about 50% for this population. So we have to really kind of think ahead and plan ahead with a lot more participants at the very beginning. And all of both of the pilots that we've done, all of the sessions have been virtual. So our hope is to do 2 in-person sessions in the next pilot we have, and do things such as doing an interactive cooking class, and also planning something where the children can create some kind of coping skills activity that they can take home with them.
So other kind of next steps that we're planning to do is to compare the pre and post results for individual participants rather than the whole group. Also create shorter and simpler interviews for the participants, use incentives to improve interest and engagement. Other considerations we're thinking about is doing rolling admissions to the group, and maybe fewer sessions. We're not quite sold on these 2 ones yet, but and then explore funding opportunities. We're done for support and research expansion.
So these are just the